Hi everyone, my name is Jocelyn, and today Taylor and I will be presenting on Ehlers-Danlos syndrome. Ehlers-Danlos syndrome, also known as EDS, can be defined as a genetically heterogeneous group of conditions that are heritable. Two men, Edvard Ehlers and Henry Alexander Danlos, were dermatologists in the 20th century who discovered the condition. Chernogubo, years prior, had seen similar presentation such as EDS in Russia, but his name is still associated with the disorder, although he did not find it. There are 14 types of EDS, but the two most common are classical and hypermobile. Classical is seen during examination with the presence of hypermobility in joints and low muscle tone, and hypermobile EDS is musculoskeletal and is actually the most common connective tissue disorder.
The key features of EDS include skin that is very soft and hyperextensible, overall fatigue, abnormal wound healing of the skin, easily bruising due to fragile skin, joint pain from joint hypermobility, kyphoscoliosis, and each subtype will experience fragile soft tissue, vessels, hollow organs, as well as the involvement of the musculoskeletal system. And classical EDS in children typically presents as low muscle tone. And on the left, provided as a figure showing examples of where the hypermobility can exist in the joints. So you'll see in the fingers, in the wrist, the elbows, knees, and then in the hips.
EDS is caused from genetics resulting in pathogenic variants in genes encoding fibrillar collagens type 1, 3, and 5. EDS because of a modification of processing enzyme in collagen. Enzymes are important in biosynthesis of glycosaminoglycan chain of proteoglycans. Molecules are essential for extracellular matrix, which is vital for tissues and organs. The classical EDS is when dominant deleterious variants result in haploinsufficiency and decreased production of type 5 collagen. Hypermobile EDS is not known for the genetic causes, but could be from age, gender, weight, etc.
EDS has a prevalence of 1 to every 5,000 people globally. However, this number may be higher due to misdiagnosis, as there are only few providers that are trained in the diagnosis and management of EDS. Along with this may come lack of confidence in diagnosing and managing EDS as well. It is more common in females than males, and there is a high correlation with other musculoskeletal conditions and diseases with this diagnosis.
Specific clinical symptoms and their corresponding occupations. Joint hypermobility, fatigue, and kyphoscoliosis are three of the main symptoms seen in EDS. A child with EDS who has joint hypermobility would have trouble with dressing because putting arms and legs through holes could be challenging. A child with EDS who has fatigue would have difficulty with personal hygiene and grooming because they would experience a lack of energy. And lastly, a child with EDS who has kyphoscoliosis would have difficult with play participation because they would not be able to participate due to decreased posture.
So, for medical management of EDS, typically with EDS, there are other comorbidities that exist, the most common one being gastrointestinal disorders. Other conditions may include POTS, which is postural tachycardia syndrome, headaches, and sleep difficulties. The most common approach in managing EDS is a combination of medications and surgical procedures. Medications are used to mitigate things such as pain, discomfort, nausea, gastrointestinal disorders, seizures. So medications may include NSAIDs, anticonvulsants, opioids, and acid suppressants. And then the most common orthopedic surgery is typically performed on the shoulder. So all of these things may interfere with participation in occupational therapy services because of their side effects. NSAIDs have side effects of nausea and drowsiness. Anticonvulsants may have side effects of drowsiness, confusion, nystagmus, headache, diplopia. Opioids may have side effects of sedation, dizziness, nausea, and vomiting. And acid suppressants may have side effects of nausea, vomiting, dizziness, and drowsiness. For medical procedures of surgeries, the greatest adverse risk for this population is delayed healing. So this may also affect the patient's ability to participate due to pain, discomfort, and then their precautions. So all of these side effects of these medications, along with the symptoms that they are experiencing with their condition, may affect their ability to participate in occupational therapy to their fullest extent.
Role of occupational therapy. To address joint hypermobility that interferes with the occupations of dressing and grooming, the occupational therapist will apply the biomechanical frame of reference. To address fatigue that interferes with grooming, showering, and completing school tasks, the occupational therapist will apply the occupational adaptation frame of reference. And lastly, to address kyphoscoliosis that interferes with play participation, the occupational therapist will apply the biomechanical frame of reference and the occupational adaptation frame of reference. Additionally, occupational therapists can encourage exercise as a means to enable meaningful occupations. They can also help with managing pain and other symptoms so the client can function better. Occupational therapists can also assist with compensatory strategies, energy conservation techniques, pacing, and environmental modifications at school and at home. They can also provide proprioceptive neuromuscular control, ligament rehabilitation, programs for sensory control, retraining. Occupational therapists can also provide joint protection strategies, as we know that our condition, the child can be hypermobile in the joints, and additionally prevent adaptive riding strategies, which is especially important for our kiddos that are in school. Other therapies can assist occupational therapists in helping to treat someone that has EDS. Physical therapy, psychiatry, and pharmacy are three other therapies that can assist. Physical therapy has been proven to be moderately effective in treating pain for those who have EDS. It can provide neuromuscular, electrical stimulation, physical exercise, hydrotherapy, massage, and muscle instability training. This would be important in assisting an OT who might be teaching a child to do their occupations in a meaningful way. Physical therapy can come in and assist with all of these different things. A psychiatrist would be able to apply cognitive behavioral therapy for pain management. CBT is what we think affects how we feel and act, what we feel and affects how we think and act, and what we do affects how we think and feel. This is important to relate to OT and to physical therapy because making sure that the client is seen as their whole body is important. And lastly, a pharmacist is able to come in and provide pain management drugs, anticonvulsants, and antidepressants. And again, that'll help all of these therapies work together as a multidisciplinary team.
The prognosis varies depending on the subtype and the environment. Early detection, early education, and early intervention can help clients identify things that they can avoid from causing further trauma. For the subtypes, hypermobile and classic are generally not affected. Vascular subtypes have a median lifespan of 50 years old due to possible vascular events that can occur. And kyphoscoliotic subtype lifespans are unknown to be affected. The greatest barrier for EDS clients is pain. This can affect all aspects of their life, inhibiting their participation in important occupations. A quote from a patient living with EDS in an article written by Schubert et al. 2024 states, "At this point, kind of feel like I'm beholden to my pain. Even though I try to push through it and plan social activities and keep those social activities, I find I often have to cancel on people because I just cannot quite manage to summon up the energy because the pain took it all, so to speak. Lastly, caregivers report that their greatest challenge from navigating EDS comes from the lack of awareness and understanding from healthcare providers surrounding EDS.
Okay, now that we've finished going through the basics of what EDS is, it's time for our case study. So, Billy is a 7-year-old African American female who lives in a one-story house in Glendale with her mother Cindy and father Randy and her 11-year-old brother. Billy's family is Christian and they attend church every Sunday. Billy's parents began noticing when she was young that she appeared to have hypermobile joints, but they thought that that was just maybe how she was born. By the time she started kindergarten, she seemed to be tiring quickly during school and would sometimes avoid playing during recess with her classmates. She likes playing handball with her peers at school, but has difficulty playing for long periods of time. She also struggles with sitting in class and handwriting due to fatigue and pain in her back. She also has difficulty completing basic activities of daily living, like dressing herself independently. Billy was eventually diagnosed with Ehlers-Danlos syndrome, where her family learned she had not only had hypermobile joints, but also kyphoscoliosis and fatigue, which can make it difficult for her to participate in handball with her peers. Billy loves to play with her siblings and classmates at school, but often has to do things differently because of her condition of Ehlers-Danlos syndrome. Billy's present level of performance, flop, is that she fatigues quickly and experiences joint pain when playing handball and doing writing tasks at school. Billy will begin to see an occupational therapist 1 time a week at an outpatient clinic to learn how she can strengthen and participate in meaningful occupations without experiencing pain and feeling fatigued.
The two occupations that the client would struggle with is handwriting and playing handball. So the first one, handwriting, falls under formal education participation in products and technologies because she would have to use a writing utensil. The client factors that would inhibit her ability to participate in the task are her decreased muscle tone, muscle endurance, and joint stability, as well as her increased joint mobility. So the performance skills needed to do this task are endures, so her ability to persist through the task without demonstrating fatigue or having to pause to stop, but because she does have weakness, this would be affected. Her ability to pace the task, so doing this at a consistent pace. Because of her fatigue, this would be affected, and her ability to calibrate, so her ability to use the appropriate movement force or speed because of her joint stability, mobility, and weak muscle tone. And then her ability to heed the task, so maintaining consistent and effective rate of performance throughout the task. And then the occupation of playing handball falls under leisure, play participation, and social play. So the client factors that would inhibit her ability to perform this task are decreased muscle power, joint stability, and then her increased joint mobility and pain. So the performance skills needed to participate in this task is stabilizing. So her ability to stabilize her body and movements throughout the task, this would be affected by her hypermobility and then her decreased muscle tone. And then aligning, so her ability to interact with the objects without propping or leaning, because she does have fatigue, this would be affected. And then her ability to flow through the task, so using smooth and fluid arm or wrist movements, interacting with the handball, and then her ability to adjust her performance throughout the task. So if she had to adjust her body and coordinate certain movements.
Thank you so much for listening to our presentation on EDS today. And then here's our references. So we have 3 slides, slide 1, slide 2, and slide 3. Thank you again.